Hi, welcome to the Policy Late. I'm Professor Paul Hoskerson from the University of Strathclyde. And could I just check everybody can hear me? Can I have a quick thumbs up? Okay, brilliant. Obviously, we were hoping to do this in person, and for circumstances that we're all very aware of, we're not doing this in person, so we're running this from our own houses, and it's been an interesting setup. I should have actually just been returning from field work in Mexico and teaching in Mexico, so it's all a bit of a shock to our system. So as I said, I'm Professor Paul Hoskerson from the University of Strathclyde, and I'm a member of the Royal Society of Biology's Council. And this event has been sponsored by the Biochemical Society, the British Pharmacological Society, the Physiological Society, the Society for Experimental Biology, and the Society for Applied Microbiology. And they've all come together with the Royal Society of Biology to really emphasize how important antimicrobial resistance and the threat to our global health is. So I'm going to talk a little bit. Everybody can see my slides? Yes? Okay, great. So I'm going to kind of give an introduction to how we work. So as I said, I'm Paul Hoskerson from the University of Strathclyde, and I come at the antimicrobial resistance problem from a different angle to many of our speakers, because my laboratory work on how some bacteria make antibiotics that we use in the clinic. But of course, the impact of antimicrobial resistance on all of us is very stark. So we've come together with this program really to try and talk to you guys and introduce the issue of the One Health approach to antimicrobial resistance. So as with many things, antimicrobial resistance is not a single issue problem. There's many factors that come together. And in order to tackle this multifactorial problem, what we need is the expertise from a whole range of disciplines that can come together to really develop a holistic approach to combat this problem. So I can just get to my next slide. So we've got some excellent speakers with us tonight, and many of our speakers have taken time away from actually dealing with the COVID-19 outbreak that we have at the moment. And of course, this plays strongly into AMR as well, in terms of secondary infections that may be the result of COVID, and long-term ventilator use has its own issues in terms of infection control as well. So after my short introduction, we have Osman Dar from Chatham House and Public Health England. We have Katharina Stark from the Swiss Federal Food Safety and Veterinary Office. We have Becky Sugden from the Wellcome Trust, and we have Sanjay Patel from University Hospital Southampton and the British Society for Antimicrobial Chemotherapy. So each of our speakers is going to give you 15 minutes or so about their expertise and introduce different aspects that relate to the One Health issue and AMR, and then we'll have a panel discussion and an audience Q&A. So you'll find at the bottom of your screen there's a little chat function, and if you can send any questions you may have to the Royal Society of Biology, and Harriet is going to work away and hopefully collate all those questions, and we can then start to talk about them later with our experts. We'll have a short audience polling and some closing remarks, hopefully from me, so I'll be scribbling away during the talks. And feel free to tweet about us on the hashtag PolicyLateAMR, and hopefully we can raise the issue of One Health and AMR again during these times of focus on COVID. AMR has been on the radar for probably the the last 70 or 80 years. So Sir Alexander Fleming, who you can see on the £5 note in front of you, raised the issue of resistance during his talk when he presented his speech at the Nobel Prize. And yet it seemed to be one of those things that people buried their head and tried to ignore, and very little attention has been paid to it in the mainstream for a long period. And then with the increase in antimicrobial resistant infections over the last, over the last 5 or 6 years, there's been a resurgence in our interest in this, and a great international effort in terms of trying to cope with this. And this Clydesdale banknote, which is has just gone out of circulation in Scotland, where I'm based, and I think it was really great to have this on a banknote that was being used widely in circulation. But I think it also emphasizes how we've come to underestimate how valuable antibiotics are, and how we use this on our lowest denomination banknote. So the review on antimicrobial resistance by Sir Jim O'Neill was published in the last couple of years. And really the stark finding that came out of this was that projected deaths from AMR, if we don't address the problem soon, could reach in the order of 10 million globally. And this will outweigh many of the diseases and the conditions that we tend to talk about regularly as a major threat to humankind. So my work is primarily on bacteria and antibacterials, but this problem really reflects the rise in drug resistance, not only in bacteria, but also in fungi and in virus and protozoan resistance. And I think some of our speakers are going to talk about various aspects. But I thought it might be useful just to introduce to the audience some of the issues around how we target organisms, to really bring home what antimicrobial resistance is, and how this arises in the population of these organisms circulating in the community. So antimicrobial resistance is defined as the ability to survive treatment with an antimicrobial drug. And this really compromises our ability to treat those infections and increases the risk to the patient, but also to the community, and can put pressure on our health systems. And most of the antimicrobial drugs that we have and use in the clinic target core pathways in pathogens, whether this be DNA replication, so stopping organisms growing and proliferating, blocking RNA synthesis, so the ability to synthesize new proteins in their cells through the messenger RNA molecules, blocking protein synthesis directly, or through the blocking of core metabolic pathways that feed into many core cellular processes. One of the other ways is to perturb membrane integrity and also cell wall synthesis, so attacking the envelope of these organisms. And by doing this, it compromises the way these organisms can grow and survive under normal conditions. And many of these targets are conserved throughout evolution and are good targets for attacking organisms with antimicrobials. But we have a shortage of new drugs, and we have a shortage of new approaches to really tackle this. And this is where the One Health issue and approach to antimicrobial resistance comes into play. So antibiotic resistance arises because, again, I'm going to focus on bacterial organisms, but you can think of a similar situation with many other organisms, is that a bacterial population is treated with a drug that may be at a concentration that's lower than will kill all of that population. And you may end up then with one single organism that survives that, but picks up mutations that allow it to survive. And then subsequently, when you treat that organism with the antibiotic again, as the infection reoccurs, the mutant population, because it's already resistant, will be the predominant organism in that infection. and then makes it more difficult to treat. And in bacteria, they have several methods in which they can become resistant. So they can produce enzymes that degrade the antibiotic as it gets into the cell. They can inactivate the antibiotic as it gets into the cell, each of them making the antibiotic ineffective. They can also modify the targets within their cells, so the antibiotics no longer hit the targets that they've evolved to hit, or you can just simply use something like an efflux pump. So as the antibiotic gets into the cell, it's pumped directly back out of the cell, so it doesn't have time to act on any of these populations. Now, one of the issues we have with bacteria and fungi is their ability to pick up mutations rapidly because they have large populations and they grow very rapidly, but also the issue of horizontal gene transfer. So this is the ability of organisms to pick up DNA in the form of plasmids. So these are small pieces of DNA that often carry antibiotic resistance markers, and you can almost think of them like the football trading cards that we had when we were children, where bacteria in the environment are constantly swapping these around themselves until they've got a full set of antibiotic resistance markers that allow them to survive under these deleterious conditions. They can pick up pieces of linear DNA, which may carry resistance markers. And the small thing here is a bacteriophage. So this is a virus that infects bacteria, but this can also carry antibiotic resistance markers between strains of bacteria and confer resistance to a new strain. So the One Health and global health approaches to combating antimicrobials is really summarized in this slide, and it's from a paper last year. And our speakers are going to talk about many of these issues today, about how individual health is really underpinned by the farming environment, the hospital environment, the environment in which we're living in, but also thinking about this in a global context in terms of how trade, migration of animals, travel, weather conditions, conflicts and displacements of large populations can all contribute to how AMR can proliferate in the environment. So without further ado, what I'd like to do is just encourage you again to tweet about the policy Late AMR on the hashtag on Twitter. And I'll hand over to Osman, who's going to tell us about the global approach and One Health approach in his capacity at Chatham House and as a consultant at the Public Health England. So Osman, over to you.
Thank you, Paul. Firstly, thank you also to the organizers for inviting me. It's very kind of you to do so. I thought, as I'm speaking on behalf of Chatham House, I don't know if I'll put my slides up, just put my slides up. I don't know how many people are familiar with what Chatham House is, but let me just see, how do I go about doing this? Sorry, just one sec. There we go. I think that's working now, right? So, so as I was saying, based in the middle of London, it was set up at the back end of the First World War as a policy institute with a quite lofty aim of attempting to prevent future war and conflict. So in that respect, it's been an abject failure, but it's famous for this rule, and essentially it's a forum which allows you to speak openly and candidly and encourage transparency, and it encourages robust debate about all sorts of geopolitical issues. So I'm going to try and approach AMR and One Health from that sort of geopolitical angle and explain a little bit about how it's in the last few years it's become such a prominent issue. Now, just in terms of the global health program itself at Chatham House, we tend to focus at issues on issues at the interface between international affairs and global politics. And so, you know, a lot of our work is health security focused. This picture here is of a bat from the Democratic Republic of Congo, from a market. Emergence of Ebola, and bats. I'm sure you're all well aware, are associated with another emerging infection, which I won't mention. So in terms of One Health, as Paul's already outlined and alluded to, the One Health concept it's really an approach, and it looks at issues across the human, animal, environmental interface. And from our perspective at Chatham House, we also look at how these issues relate to the public and private sector, and how other sectors are involved, including academia and the non-profit sectors. And the issues we typically tend to deal with in terms of One Health approaches are emerging infections, novel infections like Ebola and the one we won't mention, endemic, neglected tropical diseases, things like rabies, for example, but then also other One Health issues that are cross-cutting across human, animal, environmental health, like food security, water security, issues like that. And really what our intention is at the center is to, in a sense, we bat for the little guy. So we look at the issues around equity and transparency and operationalization, particularly in low and middle income country settings. So our focus is largely on low and middle income countries. And some of the types of work we do are we do academic publications. So you know we led on some of the Lancet series on antimicrobial resistance, but we also do stuff around into policy and into a format that will appeal and be understood by policymakers. And so those are the kinds of things we do. So in terms of what I'm going to be speaking about, I'll talk a little bit about AMR, the drivers and the interventions that are effective, its globalization and how the rise in attention to AMR was achieved, how it's framed across different settings, how this global homogenized approach to AMR has been developed, and why this might not work, and how the issue might be better framed in low and middle income countries in particular. So I won't dwell on the science because we've got some excellent scientists with us and academics with us. But one of the papers in our series summarize it very well. And you can see here that human antimicrobial misuse or overuse and animal antimicrobial misuse or overuse, in a nutshell, were amongst the highest, most important drivers for antimicrobial resistance, and where the evidence base was most well established. The other one that for us as you know, proponents of services in low and middle income countries that was of real interest was this issue of suboptimal dosing and substandard and counterfeit medicines. And while that's not an issue in, you know, we're lucky it's not an issue here in the UK or in high income settings, it's a real concern in low and middle income country settings. So we sort of summarized our paper with this diagram. And essentially what this is showing is that, that the best interventions are framed around really two elements. And one is reducing the need for antibiotics and antimicrobials in the first place through infection prevention and control interventions. And the other is in encouraging responsible use of these antimicrobials by reducing the demand and sometimes the unjustified demand, and also placing some controls on the supply of antimicrobials. And we did a bunch of studies across sub-Saharan Africa, across South Asia, Southeast Asia, and there were a number of consistent themes that would be coming across. One was, of course, in many of these settings, is inadequate access to clean water and sanitation, with animals living in close proximity to humans. Farming conditions, or there's poor infection control measures. There's, of course, the issue of infectious waste disposal systems in hospitals and farming and effluent from farming systems. And then there's, of course, the growing demand for protein across the world, and especially so in low and middle income countries. And price is a big issue, and, you know, using antibiotics in that setting as a growth promoter really helps farmers and producers keep the prices down and keep their production up. And so the economic incentives are really strong. Then, of course, there's the governance and regulations, the supply side issues. There's often poor governance, poor regulations, and over-the-counter sales are widespread. And then, of course, this is compounded by low access to diagnostics. So unfortunately, a lot of clinicians, even well-meaning ones, are forced to prescribe broad-spectrum antibiotics because they just don't know. They don't have the diagnostic tools available to them to make a more focused diagnosis, whether it's on the animal side or on the human side. And of course, then this is compounded by workforce issues, and there's a lot of quacks and informal and untrained providers, and relatively weak medical and veterinary education as well. We've got a big expansive project, for example, through Public Health England in Sierra Leone, and we supported them. This is just anecdotal. We supported them develop a whole One Health plan, and it turns out there was only two vets in the whole country in the public sector. So you can see, I mean, this is for a whole country. So you can see just how stark the workforce issues can be in some of these settings. And this slide I've just put up just to make the point about the economic implications and factors as well. Drivers. This is from European data, and it shows the association in poultry, and you can see that the resistance rates to ciprofloxacin and quinolones in European poultry are quite high. If you compare this to American poultry, which gets a lot of stick in this country over chlorine, in America they've banned the use of quinolones, and there you see no resistance or very low resistance. So the association is quite stark. Of course, the Americans have sort of undermined themselves and undo a lot of their good work in this space, and they've done so more recently with this Trump administration, because there's been this whole issue with the citrus greening. I suppose many of you will be more familiar with citrus greening than I am, but it's a disease of citrus fruit, and Florida, for instance, wants to use tetracyclines to treat this, and they've gotten approval from the Environmental Protection Agency to use over 1 million kilos of this across the state, and that's about 4 times the use of tetracyclines in the rest of animal and human health in the U.S. And this is just in one state. So just imagine they're going to be doing that, spraying this over farms across the southern and southwestern United States. So the economic incentives are really powerful. And I think that's also highlighted really nicely in this slide, which is from Denmark, where in the mid-90s, they really understood this issue of antimicrobial resistance, and they decided that they needed to disincentivize veterinarians from prescribing antibiotics in the first place. And so they brought in legislation to stop them, but at the same time they wanted to compensate them. So they made farmers, they brought in additional legislation that made farmers then have to use or consult with vets to improve their IPC, infection prevention and control processes in their farms. So the vets kept their income, but the incentive for prescribing antibiotics was removed, and so you saw a huge decline in antibiotic use. I just wanted to put this slide up because to highlight again the point of counterfeit and substandard antimicrobials, and this is about artesunate, which is an antimalarial in Southeast Asia, and you can see that 53% of sampled drugs as being sold on the market were either fake, were entirely fake, and so completely non-efficacious. And so that's a huge concern. In a sense, it's a much bigger concern than the issue of AMR in many of these settings, and this will play into some of what I'll talk about later in terms of how it's framed, how the issue is framed in low and middle income countries. So essentially as a summary of our papers and our work, we concluded that environmental C or or infection prevention control programs are chronically underfunded and required significant uplift. So the World Bank estimated in 2010 that for about 140 countries across the world, you would need between sort of 1.8 and 3.9 billion dollars a year to bring their IPC standards in the sort of food production supply chain up to sort of OIE levels. And if we think about that now, this includes everything up to the market. And you could argue that the market in Wuhan probably lacked some of those IPC standards if you're mixing wildlife produce with domestic animals. So these things have real world implications, and a little bit of upstream investment could save us a lot of headache in the future, and that's where these sort of One Health approaches come in. So just in terms of globalization and the rise in attention to AMR, I just wanted to make a few political points, I suppose, here, given the type of institution I'm representing. But AMR and resistance has been a long-standing issue, and I think that's important to recognize. So, to antimalarials in particular, it's been well known across the world. Even in the sort of late 2000s, we were already seeing artemisinin resistant widespread in Southeast Asia and spreading even to parts of Africa. But there wasn't a whole lot of attention to the issue and not a whole lot of investment. And I think it's really important to start asking ourselves, why is that? These are diseases of poverty. They affect millions of people. They cause hundreds of thousands of deaths every year. Yet nobody was really talking about AMR at that time. And why is that, right? Even with HIV, we've seen there were significant resistance across sub-Saharan Africa. Of course, the issues with multi-drug resistant tuberculosis, which is an ancient scourge, are well known. And again, there was huge increases of MDR-TB, but not a huge amount of investment in it, not a huge amount of attention to drug resistance when it came to TB. And so why was that, right? We really have to ask ourselves this. Even extreme resistant TB, which was resistant to just about everything, was being reported through the mid 2000s, and yet there wasn't a huge amount of investment in the AMR space or attention to it. So what happened? And I think this was the sort of question that I'd wanted to ask, and for all of you to think about and consider. What happened? Well, we started seeing huge, as a result of globalization, we started seeing huge increases of antibiotic use in hospital settings and secondary care in these emerging economies, in low and middle income countries. And really what started worrying people in the global north, in North America, in Western Europe, was that these resistant bugs would come into our settings, into our countries. And so it became a security issue. And there was a securitization of the issue, which increased the attention and the funding and the spending in the space. And I think this had some real and this has some really important implications. But at the same time, it was one of those issues where it's a theoretical risk, and so how do you ramp up attention? And get governments to really take notice, sit up and take notice, and then start investing in strategies and mitigation measures. And so our chief medical officer at the time, Sally Davies, who many of you may be familiar with, she was a real champion of the AMR issue. And we had a meeting in Chatham House in 2013, and one of the discussions at that conference was, how do we raise this as an issue at the global level? What do we need to do in order to ramp it up, the list of priorities? Because it's a minefield there of lots of different issues. And so the idea was put forward that the Stern review was done in 2006, which modeled the economic impacts of climate change. And that's how climate change became such a big global issue. So the thing here was that, okay, maybe we should do something around. So that's why Jim O'Neill, who was a Goldman Sachs economist who coined the term BRICS, was chosen to lead that review. So, you know, at first look, you'd be like, why isn't a scientist or some biologist leading an AMR review? Why is an economist leading it? And it was to make that sort of marketing case and case to politicians and the government that this is a real a big issue. And in terms of as a marketing strategy, it worked wonders. And you know, we had all kinds of world leaders jumping on the AMR bandwagon and making statements. There's this other chap at the bottom, Matt Hancock, who just until last year was saying that this is sort of the biggest danger that we have. And of course, it turns out emerging infections are, you know, were perhaps a more acute risk. But in a sense, you know, the marketing worked really well, and so we bought. In a sense, we bought some of our own propaganda around this, and I don't mean to downplay the risk of AMR, but I just want to impress upon you how you know, a particular issue is brought to the fore and prioritized over everything else when there's a lot of competing risks in the space and limited funds and attention to address those risks. So it became an issue at the G7. You know, there was a UN summit around it. And even Paul alluded to some of the figures that were touted in saying this, because even though Jim O'Neill happens to be the chairman of Chatham House now, but I'm quite comfortable saying this. But if people actually look at the report, what it's saying, the headline figures are alarming. But what it's saying is that 10 million people will die by 2050. But if you look down into it, what it means, and this is a report done by the RAND Corporation, so that should give you a little bit of insight into how the report's done. So the RAND Corporation is a big private consultancy out of the US, not exactly a public health institution. So they have their own way of presenting data. And the 10 million figure is if every, was calculated by assuming that every single infectious disease infection around the world, whether it's HIV, whether it's TB, whether it's malaria, whether it's you know, bacterial infections, if all of them were 100% resistant, then we would get 10 million deaths a year, and then we would have and the deaths ensuing from that from people, you know, dying at a young age would result in a hit to the global economy of $100 trillion. I'm still not clear on how you can come up with a figure like 100 trillion, but that's where we were with that. So it's just to impress upon you that, you know, there's always that devil in the detail with things like this. And so as a result of that, we were able to put AMR on the UK risk register, and that yellow arrow at the top is still, and then also made it onto the risk register. And these things are all about timing, in a sense, you know. So when the WHO launched their first AMR strategy, which was a really excellent strategy in 2001, the timing of it was all wrong. They released the strategy on the most unfortunate date in that year, which was September 11th, 2001. So the whole launch of that strategy just got buried under, you know, obviously the planet's overwhelming news story. And so AMR just really made it up the political agenda, and didn't get the attention that it probably deserved even at that point. But in 2015, 2016, there was this sort of convergence of these security issues, health security issues, and rising antimicrobial resistance. So it was the right time for this kind of issue to be brought to the fore. And I think it's important to then just reflect a little bit briefly that I have left on what came of the AMR review. And as I said, as an advocacy tool, it was, you know, it had a huge impact, and everyone sort of quotes these figures all the time. But in terms of concrete achievements, what has it really achieved? Now, certainly on the funding side, it's achieved a lot because a number of research funds were set up to develop new antibiotics, because that was one of the issues that was identified, that there's not enough in the pipeline of new antibiotics. But again, here there's a real issue, because and we were part of a European project that was looking into this, like how do you incentivize companies to develop new antibiotics? And the people tout things like, oh, you need $1 billion to take it to through the phase 3 trials and develop the drug. But really, the fundamental underlying issue is that it's far more lucrative for drug companies to focus on chronic disease drugs, and the whole overarching system of drug development and incentives and the profit making that big pharma is able to accrue means that it can never be you can never sufficiently incentivize them to make antibiotics. They will always be market failure with antibiotic development. And so there's a lot of funds by a lot of donors on the more upstream blue skies science bits of antibiotic drug development. But in terms of then taking a promising candidate to market, where they're really expensive clinical trials are necessary, there's very little money and there's very little incentive for companies to do that, because the return on investment from doing chronic disease drugs or asthma drugs or whatever is so much higher that why should they take a risk with even $1 billion? So the incentive isn't there, and really that's an issue that's much bigger than just creating a fund to support antibiotics development. Now, the other thing around the health security that I wanted to just mention was that at the same time, because of 9/11, because of the U.S. Worries around their own security, they started funding what was the Global Health Security Agenda and a Global Health Security Initiative, and this was focused on identifying laboratories and sites where malign actors might be using viruses to create biological weapons and that sort of thing. And so a lot of funding was put into capacities in relation to global health security, and AMR was bundled into that whole narrative. So a lot of work was done around that. Countries have had national AMR action plans, and a whole series of countries have had these across the world. But they're only funded and they're only effective as long as there's external donor money coming into that. They don't tend countries, and so sustainability is a real issue. So you can show that this plan is working, it's people are acting on it, but they're not expending their own domestic resources on it. So as soon as that external funding dries up, they stop funding these programs. And the reason is because the issue is not being framed in their own national interests. If you're framing it in terms of us needing you to build surveillance capacity, or we want to know how you're doing biosafety, then they're not going to invest in those capacities with domestic budgets. If you frame it around the interventions that do work, like water, sanitation, vaccination programs, the preventive measures, the upstream measures, then they will invest in it. But the issue is that it's never framed that way, and that's highlighted in the sorts of indicator sets that global programs then ask countries to collect. So this is from the International Health Regulations Monitoring and Evaluation Framework, which is the overarching agreement that countries use to assess each other's capacities around infectious diseases, around antimicrobial resistance. And you can see all the indicators are framed around detection, around surveillance, around healthcare associated infections. And that's because those are the issues which are of interest to high income countries. They're not necessarily the interventions or the issues that are most effective in low income settings, but that's what the low income settings are then expected to collect and report on if they want to get any donor or external funding. And that's become a real issue, and that shows even in the review of the O'Neill report, which we did 5 years after it was first launched, which showed that many of the problems in low and middle income countries have largely persisted. And we really have to ask that question: are we being honest? And when we expound the risks, we speak of antimicrobial resistance and include HIV and TB and all these neglected diseases in framing the risk, and that's why you're able to produce figures like 10 million deaths. But when we design surveillance and when we design interventions, we're only thinking of antibiotic resistance, because that's the security risk to ourselves here in high-income countries. And really, if we want a global system that's effective and that is actually dealing with the problem comprehensively, we're only as strong as our weakest links. And so it's really it's in our own enlightened self-interest to frame it in the appropriate way for these low and middle income countries. I think I'm probably running over, so I'll just draw it to a close. But really, I just wanted to end with how the issue might and could be framed in a low-income country setting, low and middle-income country setting. And I think framing it as an issue of sustainable access to effective antimicrobials rather than resistance itself is really the frame that we should be taking. Because in a lot of these settings, they don't even have, access to an antimicrobial or antibiotic. So it's quite ridiculous to go and ask them about resistance or ask them to monitor or surveil resistance. Or provide that kind of data when 60-70% of the population doesn't even have access to basic penicillin. There needs to be a harmonization around donor and development assistance, and it needs to be done in sync with nationally and regionally determined priorities. And I think where the evidence base shows that hygiene, water and sanitation programs and IPC programs, including vaccines, are the most effective interventions, and that's what should be funded as part of a health security strategy, rather than this over focus on surveillance and on mapping laboratories and what's happening in hospitals in low income settings. I think I'll probably end there. Just to say again that the issue of counterfeit and substandard antimicrobials is a real problem in low and middle income country settings. And I think the best way to think about these things is to put yourself in their shoes, really. And if we had in this country substandard or counterfeit antibiotics in our hospitals or in our neonatal intensive care units in the sort of 30, 40, 50% type numbers, would anybody be speaking about antimicrobial resistance? It would be a national scandal. Everyone would be fired and never work again if in those settings. So really, why should that be any different in a lower middle income country setting? So I think that's one of the messages I have is we should always try and put ourselves in someone else's shoes when framing this or any other global health program. Thanks, Paul. Sorry for droning on.
No. Thank you, Osman. I think you've made some really interesting points, and I'm sure we'll come back to several of those in the discussion later. So I think you might need to unshare your slide, Osman. Brilliant. And then next up we have Katharina Stark from the Swiss Federal Food Safety and Veterinary Office. And Katharina is also an honorary professor at the Veterinary Public Health in veterinary public health and policy at the Royal Vet College. So if I can hand over to Katharina, and she's going to share her slides. Fantastic. Thank you, Katharina.
Thank you very much. Can you see my slide?
Yes, I can see your slides and we can hear you.
Okay, thank you very much. Thank you very much for inviting me to speak here. I think while listening, I was thinking like this, my perspective is going to be slightly different. First of all, I'm a veterinarian and I work as a specialist in veterinary public health for the Federal Food Safety and Veterinary Office here in Switzerland. So I obviously have a sort of a developed country perspective. Switzerland is also not member of the European Union, but I think we also have very much a European perspective on this. And so also I'm a veterinarian, so my focus obviously will be around animals and food, and the role this has, or antimicrobial usage in these animals has for public health, and therefore for One Health. My role here in federal government in Switzerland is that I'm head of department for animal health, and that's actually the department that is regulating antimicrobial usage and resistance surveillance in animals. So that's the AMR part covered, but also the department is hosting the Secretariat of One Health, and so that's also kind of bringing in. And that's quite interesting, actually. So I'm just giving you some background on this One Health Secretariat. The role of the Secretariat is to coordinate cross-disciplinary activities across ministries, both at federal and state level. And the Secretariat was created on the legal basis of what's called here the Federal Law on Epidemics, and that's the law on epidemics in people, just to be clear. And this One Health Secretariat was created as a reaction to previous pandemics, specifically the avian influenza, and then also the swine flu issues have shown to the government here. I was not involved in that, so I cannot claim any credit. But it has clearly demonstrated that the veterinary aspects need to be considered when we are faced with pandemics. And now, as we are having this webinar, of course, we are all also dealing with issues linked to the COVID-19 situation. So it's kind of interesting how also this webinar kind of reminded me myself of the relevance of what we are talking about, my own department, my own role, and the current challenges we have. So I have very few slides, so I hope you will not get too bored. I have structured my talk into basically 3 parts. So I want to talk about the connectedness between the different compartments, so animals, food, environment, and people, and how AMR growth is relevant, or how these different compartments are relevant for AMR, and then also for the health of people, so also for One Health. And then I want to talk about policies. These are current policies we have. I'm going to focus on policies in Switzerland, but I think they're very much in line what is INCA recommended. National organizations have already been mentioned, the FAO and also the OIE. And then finally, I have been encouraged to also integrate aspects of the current situation around COVID-19. And to be honest, my first reaction was, okay, so that's not very connected to AMR, but the more I, obviously over time, and things are quite dynamic at the moment, it has become clear that it is very relevant indeed. So I'm going to my next slide. So I want to start out, and this has already been mentioned by previous speakers. Of course, antimicrobial is not limited to any of these compartments that I'm showing here. So when we use antimicrobials in animals, bacteria in the guts, mainly of these animals, might become resistant and can then be transferred, if these are food animals, to people, and have negative consequences when people fall ill and cannot be treated. But also because the absorption of antibiotics in animals is not very effective and efficient, a lot of these substances get into the environment and create then resistance in bacteria there, which again can be transmitted to people or come back to animals. And you've seen these graphs, I'm sure, in other places. This sometimes referred to as confusograms. And I guess, you know, this complexity of the problem is a huge challenge. And we are only just starting to understand the relevance of specific aspects. And this is where it is very interesting in terms of the science, to go into the details and to understand about the impact of different elements, or even to the gene level, to understand fully how these different compartments are connected and how perhaps certain interventions can be effective directly or indirectly. However, from the policy perspective, it's of course not necessarily needed that we fully understand all these aspects. And also we will lose a lot of time if we are not ready to act until we have a full, or what we might consider a sufficient understanding of these different complexities. So we are taking a very much, we as the Swiss government, or the Swiss Veterinary Service, are taking an evidence-based approach. So we would like to use policies that can be based on our current understanding of the interaction of these different compartments. But we also, I think, we take quite a pragmatic approach. And I would like to, on this next slide, go a little bit more into the detail of these different policy options that we are using and are continuing to develop. And I think when I started to prepare this slide, I think really the central assumption here is that antimicrobial usage, and I'm talking about livestock, but also about usage in pets, so in all animals in this context. This is the key driver of resistance. So if we want to introduce policies, and if we are interested in establishing the effectiveness of these policies, we need to see a change. So that means we need to monitor, or we need to keep tab of how much we can reduce usage, and then also try to link that back to the resistance situation. So this is why surveillance is a very central part, and data, or let's say evidence in general, is a very central part of all the policies that we are implementing, and we are constantly trying to improve. Now, in terms of knowing how much is used, we here in Switzerland, we have developed quite a comprehensive database, and it's built around the veterinary practices that have to record all the prescriptions, and that they make both for pets but also for livestock animals. So this has only started last year, so it's quite new, and we are only at the beginning of cleaning the data and being sort of confident enough that we can analyze the data, and then in the future use it also for feedback to these practices, to let them know how they are doing in terms of benchmarking, and I'm going to get back to that. Now, how to reduce usage. Obviously, we are assuming that prescriptions of antibiotics are used evidence-based, so we need to improve animal health if we want to reduce the need for usage. So this is our key focus, is we want to improve animal health, and we have also developed an animal health strategy that reflects that. So that means also we are focusing a lot on prevention. So that means vaccines, but it also means improved husbandry systems, hygiene, and sort of kind of, let's say, biosecurity, the more basic aspects of animal husbandry. We believe that if animal health is improved, that also has positive side effects. For example, animal welfare is improved. And also we could show, or it has been shown also in other countries and other settings, that it can even be for farmers to reduce or to improve animal health, because then these animals produce more effectively. Obviously, then also are zoonotic, and that links back to people, and also the economic effects in our understanding are important of the One Health understanding. Now, to make progress on this aspect, and animal health particularly, we are developing specific disease control programs to eliminate diseases that require antibiotic treatment. But we also feel that we need to be to learn more about how we can change practice, how we can change the attitude of farmers and veterinarians towards antibiotics, and how we can use social science approaches to make progress there. We feel that veterinarians and farmers tend to be quite risk adverse. So if we want, and so they use antibiotics sort of almost like an insurance. And if they have used it for many years, it becomes difficult to convince them to take the risk to do without. So we are working with social scientists to understand better how we can increase the confidence, or how we can make farmers and veterinarians be able to deal with the uncertainty and change their attitude towards using antibiotics. And then we do believe that once we get more data on the usage, also to use benchmarking will be quite an effective policy instrument, so that farmers and veterinarians will be able to compare the usage with similar practices, similar farms, and that should provide an incentive for them to reduce if they have above average usage. At this point, we are not establishing reduction targets. I'm aware that other countries have used and are implementing reduction targets, countries in Europe particularly. Some of these targets have not been fully evidence-based, I would say. They were kind of political targets as well. At this point, we are not planning, or we have not established such targets, but it might be something that we might consider in the future. So this is sort of a quick overview on different options, policy options on the veterinary side. I have not gone into the detail. Antimicrobial resistance surveillance, obviously that's an important element here in closing the cycle here, linking usage to the resistant development in the end. This is challenging because the linkages are not always direct. So if you reduce usage, you might not always be able to see the effect of that, or an impact on resistance quickly or directly. This links back to the complexity that I've mentioned before, the linkages between these different compartments. Okay, I want to say a few words about the COVID-19 situation and how it links to AMR in my personal experience, and also based on some papers that I have been reading internationally. What we have been dealing with primarily over the last weeks is in the context of One Health, and this is not directly linked to antibiotics, is to deal with shortages and disrupted supply chains. We have noticed that many products, for example, protective clothing, masks, but PPE in general, but also medicines, anesthetics particularly, are used, of course, in human medicine and in veterinary medicine alike. These are the exact same products, and if there is increased demand on the medical side, on the human side, so that will put reduce accessibility for vets. I'm aware from my colleagues in the UK that there have even been donations made from veterinary clinics in terms of not just substances, but also equipment, ventilators, etc., for use in human medicine in hospitals. So I think that's a linkage, perhaps that is a little bit different, but it's very relevant. Then, of course, the agent, the SARS coronavirus 2 is a zoonotic agent, so I'm perhaps going to come back on to that a little later. And then also in terms of the antibiotic use, a lot of the patients, human patients, are also being treated with antibiotics, even though this is a viral agent. I have been reading in some papers that more than 90% of COVID patients in some cohort are receiving prescription of apparently the prescribing is particularly high in telehealth settings. So if patients cannot get to a physician, see them face to face, then the prescription is even higher. So that means usage is increasing. And then also there is exploratory therapy, some of which involves use of antibiotics for treatment specifically against COVID-19. So this is not for secondary infections. So both of these, although I'm not an expert on the details, but obviously this will increase antimicrobial usage and therefore also have an impact on resistance in general. So this is not in animals, of course, but if you have an increase in resistance in sort of the ecosystem, and there have been some calls of concern out just today and over the past few days that the COVID-19 situation will set back progress made in the reduction of antimicrobial usage and therefore resistance by several years. So this is a threat, I think, in One Health context, because of course if resistance increases, that animal health. Just on the aside, I mean, I mentioned the zoonotic aspects. We are learning every day new aspects of this virus, and of course since it's emerged from an animal host and is also able to infect a number of animal hosts, including some pet animals, that puts additional challenges on us and also highlights the One Health aspects. Just today it was communicated that mink farm in the Netherlands were affected, and apparently some of these mink transmitted also the virus back to humans. So this is another illustration how this virus is very relevant in a One Health context. So this is all I wanted to talk about, really. I think being in the center of an ongoing pandemic is testing the robustness of our One Health collaborations in an unprecedented way. And it is perhaps too early to reflect and to discuss lessons learned, but COVID-19 will continue to provide us with ample opportunities, I think, to practice One Health even more and better. And I'm looking forward to the discussion. And now I will try to stop sharing if I manage that.
Thank you, Katharina. That was really fascinating. And I think it's fundamental that we bring in veterinary science into this One Health approach to combating antimicrobial resistance. So our third speaker is Becky Sugden. So Becky is a policy advisor in AMR at the Wellcome Trust. And Becky's going to talk to us about policy and advocacy considerations in the fight against AMR. So I'll hand over to Becky. Thank you.
Sorry. Okay, so hopefully everyone's able to see my screen and hear me. Thank you very much, Paul, for the introduction. As Paul says, I'm a senior policy advisor at the Wellcome Trust, working in their drug-resistant infections team. I've been here for 3 years. Prior to that, I worked for Professor Dame Sally Davis, who at the time was the UK Chief Medical Officer, and did a lot on pushing the topic of AMR, as Osman has referred to, and continues to still be one of the major advocates now that she's moved on from the position of Chief Medical Officer. Just quickly, for those that don't know, Wellcome Trust is a medical research charity. We spend about $1 billion a year funding research, both here and globally. I'm part of the drug resistance infections team, as I said, and that's a priority program within Wellcome Trust, where we're focused on measures to address AMR. Sort of uniquely, certainly within Wellcome Trust, we have a mix of science officers and policy advisors within the team. And what we try to do is take the approach of commissioning science research that will inform policy gaps, so that we can improve our knowledge and help support policy development. And we also base our policy and advocacy aspects on the science. I think, as we've heard a lot from the previous two speakers, AMR is complex. There's no one solution, and there isn't even one sector that we can turn to. It's described as a One Health, bringing in aspects of human, animal, and environmental health into the problem. And it also, we have different sectors, different groups of actors that need to be brought into the response. So we have government, civil society, private sector, research, and philanthropy. So from a policy and advocacy perspective, it's not easy. There's lots of messages and lots of things that we need to deal with. And this slide here, I've just tried to give you a bit of an idea of the different policy areas that we are trying to cover in antimicrobial resistance. And it's not even these at one level, because as we talked about, it's One Health and there's lots of players. So if you take surveillance, for example, that's policy and advocacy aspects on surveillance in human health, animal health, environmental side. And then as part of that, we need data that's contributed from governments, academia, civil society, private sector. So AMR is often referred to as a jigsaw puzzle, and we need the different players to be bringing in their actions, and we add them all together and end up hopefully with an overarching puzzle that brings it all together, and we have a response. But it's tricky. So we take what's called a systems approach. We look at the contribution of the entire One Health system and try to prioritize solutions and areas that are having the greatest impact, or where actions are taken, they can have the biggest effect first. One of the things that's sort of difficult is that because of all these different areas in this jigsaw puzzle, AMR can seem overwhelming, particularly when you go and talk to a government about it, that they've perhaps not really thought about it before. And if you try and say everything on this slide, they're just going to respond and say, it's too difficult, there's too much to do. So one of the things that's really important is thinking about how we frame the messaging and prioritization. We have to clearly define the problem, and we have to go in with a clear call to action and make sure that we're thinking about our audience and what is key and relevant to them. Wellcome Trust did some work last year, which was about how we communicate AMR with the public. I think it's really relevant generally in the policy and advocacy space about how we talk about AMR. So they came up with 5 key principles, which I'm going to briefly go over, and you can read the information on the screen. But first of all, it's really important to get the message over that drug-resistant infections undermine modern medicine. Many of the treatments that we know and well, like cancer, diabetes, as you all know, they're all reliant on having effective antimicrobials. And if we lose that, then we lose those treatment options. So we need everyone to understand. We need to explain AMR properly to the public. It's very easy to, well, not just public, government, non-scientific audiences, to explain it in a scientific way, which people don't understand. One of the common misunderstandings is that the individual is the one that becomes resistant, not the microbe. So we have to really think about how we're framing it and what we're saying. We have to make sure that everyone's aware that AMR is a problem that affects everyone, including them. It's very easy to think it's something that won't come to you. And we also have to be clear that AMR is a problem for now. So things like the O'Neill report and things that Osman was referring to are great, and they really do show the extent of the problem, but a lot of the data shows the extent of the problem in 2050. And that's quite a neat excuse for governments and organisations to think about, well, I'll do something later. Whereas actually AMR is a problem now. It's affecting people in countries, and we do need to start taking action. So we need to start framing it in that way. And we also need to frame AMR as something that can be solved. With all those complexities, as I said, it can be easy to think that it's too difficult, it's too big a problem. So we need to be going in with that clear call to action on what needs to be done, and what those specific individuals can do as their part of contributing to the jigsaw puzzle. So given all those different policy approaches, I could go into all of them and talk about all of the policy considerations, but we would be here a long time. So what I'm going to do is use the example of new antibiotics as a policy area, just to talk about how we at Wellcome think about that and all the different considerations we need to think about in that bit. And just bear in mind, this is, as I said, only one piece of the puzzle. So until the mid-90s, there was a steady stream of new antibiotics and antimicrobials being developed, as you can see in this chart. And then we started to see the fall off and then into a discovery void, which is likely to be due to a number of factors. Firstly, all the easy ones are found first, so the low-hanging fruit, we find these ones, it's easy, quick to take them through the R&D process. And we are confident that there are new classes of antimicrobials out there, but it's going to be harder. So this adds to the R&D costs and process times and just makes things more difficult. Added to this, you've got the issue that when a new antimicrobial does come to market, we're not going to be looking to use it straight off. When you get a new drug, normally, you guys will all be very aware, given your background, that a pharmaceutical company would want everyone to be using it. They'll be promoting it and trying to get pickup. Whereas with new antimicrobials, we want to hold them back. We want to keep them for when we have those resistant infections that aren't responding to anything else. So unlike other models where maybe you have a pill that's taken every day or something like that, there's not really the markets once they make the drug to sell it in volume. So taken together, as you can see on this slide, there's been a bit of an attempt to do the estimated cost of R&D for bringing something through to market. And this has just led to us seeing pharmaceutical companies leave the market. And even worse, we're seeing small and medium enterprises actually going bankrupt as a result of this. They don't have the funds to get through, and no one wants to pick it up afterwards. So policy discussions really need to focus around how we can incentivize pharma to get back into this space. So on this slide, this takes you through sort of the basic options that we have, or high level options that we have when it comes to incentivizing the pharmaceutical industry to get back into antimicrobial and particularly antibiotic development. So on the left, we've got the push incentives, and these are very much designed at the early stage development, and they will probably be helping academia and, as I said, small and medium enterprises to get through those early stages. And there's been some reasonable success on that space. For example, at Wellcome Trust, where we have made a significant contribution to a non-profit partnership called CARB-X, which is purely dedicated to accelerating antibiotic research in that early stage. But we've had less success on the pull incentives side, and that's a problem because we are currently seeing companies, small companies, who do manage through funding and through CARB-X to get their product through that early stage. But because there isn't the incentives there for the big pharmaceutical companies to then take those products and do the final stage of development and commercialize, we've seen companies with viable products going bankrupt and those products not getting to market. So at Wellcome Trust, we've been trying to push and facilitate some of these discussions at the pull incentive end. We've been bringing stakeholders together, particularly in the pharmaceutical industry and in philanthropic and investor organizations like ourselves, to see whether there's some sort of public-private partnership model that we can bring together that would have that pull incentive that would tempt big pharma to come back to the market. Things are looking promising here, and I think we're keeping our fingers crossed that there might be some announcements later in the year. But at this stage, I can't provide any details on what that might look like. It's all still being worked through with the various players, and it's still all a bit sensitive and difficult. Everyone's got different considerations, and there are some big risks involved. So still trying to work those through. But that's the sort of policy and advocacy work that we're trying to do. In addition to these obvious pull incentives and push incentives and incentives in general, it's not the only thing, it's not the only part of the puzzle when it comes to new antibiotics. It's not just that we need to sort that bit. There are other things that we can and should do to support and build around this. And we're trying to engage in that, and a lot of it focuses on preventing infections in the first place. So through one of the other priority programs in Wellcome, we are looking at vaccines specifically to address AMR issues and what we can do to fund and work out what those need to be. Diagnostics are really important. You guys will be really well aware of the fact that at the moment a lot of antibiotics are prescribed because the clinician thinks that someone may have a bacterial infection, and in some cases they're prescribed not even by a clinician but just because someone thinks they should be. And even where a clinician thinks they're doing or is basing their stuff on doing the right thing, they don't have a diagnostic test, and it's not always obvious to define between what is a bacterial and what is a viral infection. So we need a lot more quick, rapid diagnostics that can really help in the clinical setting. Not even in the clinical setting, if we think in different countries and the way medicines are prescribed, sometimes you need to just be getting it to the local provider who is selling or giving out medicine so that they're able to do it. They're a really key part of it. We need stewardship policies in countries. The UK were pretty good, but other countries, we need greater clinical guidelines to help people work out when they should and shouldn't be using antimicrobials. But this comes at a cost in some countries, and we have to be really careful that those policies and procedures don't impact on access. There's still, in quite a large proportion of the world, more people that die because of lack of access to effective antimicrobials than die from resistant infections. So anything that we bring in from a stewardship basis, we need to make sure, and as Osman was saying, that access is really core. So any stewardship programs, particularly in developing countries, need to not impact on availability of antimicrobials when there is a clinical need. So there's all these balancing of different areas that need to come in when we're talking about policies, and also the different players that we need to bring into the discussions. So in this area, I've clearly talked about talking to private sector and philanthropic. There will be governments that need to be brought into incentive models, and also how we build up these stewardship and access frameworks. So there's various different bits of the puzzle, and as policy professionals, we need to prioritize the areas that we go for, and also when we are talking to people, think about the messaging and the actions that they need to take and make it very clear and obvious so that they're able to pick out what they need to do. Finally, I'm very happy to pick up on more policy areas in the Q&A, but finally, I just wanted to reflect, as others have, on the impact of COVID on AMR advocacy. COVID obviously has now been declared as a pandemic, and there are many who work on AMR who would say AMR is a pandemic. The problem is it's been slower to develop, and also it's across many different disease areas. So we don't add it all up. We just have TB and we have malaria and we have different bits. And so that's why it hasn't been recognized as a pandemic in the same way we have with COVID. And interestingly today, actually, I saw a stat, and don't quote me on it because I don't know the source, so I just want to, but someone mentioned that in the time it took for us to get to 200,000 deaths on COVID, there had been 500,000 deaths on TB, HIV and malaria, and we're not hearing those statistics. So there is a thing now about how much we're able to balance. But as far as AMR is concerned and advocacy work, now's not quite the time to be pushing those messages. Everyone's highly focused on the COVID response, and we need to hang fire a bit and wait for the right opportunity to start bringing AMR messaging in and linking it to COVID. But there are some really obvious bits which, from the policy areas I've mentioned, where you can see the links. So surveillance. We've been talking so much about the importance of surveillance. In the UK, we're really lucky. We've got good surveillance systems, and COVID was picked up pretty quickly once it came here. And we have pretty impressively ramped up our testing capability. I'm not going to get into whether we could have done that quicker, but in comparison to how many other countries have done, we have a really good, robust surveillance system that covers like the entire country. It's not the same everywhere else in the world. So if you look at Africa, the numbers there don't seem as bad. And that might be for two reasons. One, because they're behind us on the curve. But having been on calls with colleagues in Africa, actually probably more their greater worry is just the fact that they don't know. They don't know the scale of the problem because they don't have the robust testing systems that we have here. So what can we learn about surveillance? And one of the things I was thinking about was, what if COVID had started in Africa rather than China? China's surveillance systems are better than in Africa. Would it have had longer to run and become a greater problem before we've been able to detect it? And it's these sorts of things we need to bear in mind and support people. And I do take into account, I'm slightly contradicting Osman here, who's very much talking about other areas that we need to focus on first. And I do completely agree with him, and I'm just about to move on to that. So sanitation and hygiene, COVID has thrown us straight back into the basics of public health. We have no treatments, we have no vaccines. All we have at the moment is basic public health measures through sanitation and hygiene and distancing to stop it spreading. We're lucky, most of us have access to water and soap, and we're able to wash our hands and stuff. There are many areas in the world where that isn't possible, and you've got many healthcare facilities where they don't have running water. How do you stop the spread of infection in those situations? And I completely support Osman in terms of there are some basics and there are some things here that need to come out that would not only impact COVID, but would have a very significant benefit for AMR as well. If we can stop the infections through better sanitation and hygiene, that's got to be all the good. Obviously, there's vaccines. You'll have heard a lot about discussion about vaccines for COVID. I'm not going to go into that very much, but same discussions we have with AMR. And access. Hopefully you've all been hearing the discussions about vaccines. When they do become available, there's a real issue about whether high-income countries or the countries where they develop them in might hold them back and serve their own populations before we serve the rest of the globe. We really need to make sure there is equitable access to therapeutics, both for COVID and AMR. We can't just take the approach that we need to sort us out. We're not safe until all of us are safe, and that is a really key message that's applicable to both COVID and AMR. We've got the One Health approach that Katerina was talking about. COVID is showing us the real link here between humans and animals and how we live together and the risks that pose. And just finally, preparedness. So for many years, governments across the globe have failed to properly invest in preparedness, and we're seeing that now. It's kind of understandable. investing in preparedness is not a sexy thing to talk about when you're campaigning for re-election, because the public don't see any benefit for it. If you do preparedness well, then people shouldn't know about it. We only know about it when we've not done it well. So it's very difficult to have that as your campaign message. But it's really important, and investing in it is really important. Even when you've got other priorities, we are now seeing the economic impact of not investing enough in preparedness. And that will be the same for AMR as well. And I'll leave it there, and happy to pick up any of the policy points and stuff in the Q&A.
Sorry, I'd forgotten to unmute myself. Thanks ever so much, Becky. That was a fantastic talk. Lots of points to come back to later. And with no further ado, I'll pass on to our last speaker of the evening, who's Dr. Sanjay Patel, who's a consultant in paediatric infectious diseases at University Hospital Southampton, and is also British Society for Antimicrobial Chemotherapy Officer for Stewardship and Surveillance. So I'll hand over to Sanjay. So thank you, Sanjay.
Well, thank you very much, and some fascinating talk so far. Is that a full screen for everyone? Is that all right, Paul?
I think my computer's slightly behind you.
Yes. No,
okay, full screen. Brilliant. Thank you.
So we've heard some amazing talks this evening, and a real slant on policy. And I'm going to take a very different tact in this last talk. I'm not a policy writer. I'm a frontline clinician. I'm a paediatric infectious diseases consultant. I work in England. And I am really interested in some of the social science aspects of antimicrobial stewardship, clearly recognizing that you need the policy in place that underpins it. And we really have that, is the honest truth. I think gram-negative resistance took us by surprise. We were all very focused on MRSA in the late 90s, early 2000s. And then out of nowhere, we saw this rapidly escalating issue with resistant gram-negative infections, which has been hugely problematic and resulted in the UN meeting at an extraordinary meeting in 2016. And on the back of that, many countries in the world have got action plans. And in the WHO produced stuff, and in the UK, we had a plan that began in 2013, and we've got a 5-year plan that started last year, and we've even got a 20-year plan. And when you look at the metrics, and I think Katerina was talking about data, I think data is so fundamentally important. We have annual reporting from ESPAR, which is comes out of Public Health England. And when you look at crude data such as these, which is absolute antibiotic prescribing, it seems relatively encouraging. And unfortunately, I'm not so encouraged by what we've seen on the back of a huge amount of policy and a huge amount of discussion. And I think on the ground, we haven't perhaps seen the same radical change. And I'm really focusing on high-income countries here, not middle and low-income countries, but we've not necessarily seen the changes in behaviours of frontline clinicians that justify our excitement with the momentum that antimicrobial resistance and stewardship work has taken. And when one looks at some data, and I'm not really going to go into these studies in much detail, one feels that in fact, from a prescribing perspective, we should be looking at 20 to 50% reductions in antibiotic use, as opposed to the mere 10% that we've seen in the past 4 to 5 years in the UK. And that's primary care data. That's absolute data. These graphs I'm just putting up now are hospital data. And you'll see that we've made no iota of difference at all in terms of antibiotic or antimicrobial use in hospitals. And if anything, for some of our broad spectrum antibiotics, on that left-hand graph, we've got some of the cephalosporins, which are very broad spectrum. And here we've got the quinolones, a drug like ciprofloxacin. And you can see all those graphs are moving in one direction, and it's not downwards. And I think that's very disappointing, and we've got to ask ourselves why. And you'll see here, and as we've heard from the previous 3 talks, there is a huge amount of policy work going on with antimicrobial resistance. And I think from a reality perspective, and both Becky and Osman have articulated it beautifully in both of these settings, in high-income countries and in low-income countries, something has gone wrong in terms of the framing, and as a result, in terms the reality of what's happening on the ground. And those last graphs I showed you confirmed to me that we haven't quite got it right, and there is an implementation gap. And that's probably what I'm going to focus on for the next sort of 10 or 15 minutes, some practical examples of what we need to think about and probably focus on. I'm not going to speak much about research, but I think this implementation gap applies as much to research as it does to policy, that getting things implemented at the front line takes a huge amount of energy, and it's often we spend the money on our research or on writing grand documents, and we only pay lip service to some of the implementation. And although I'm going to focus on healthcare settings, either both hospitals and community-based prescribing, there's a lot of transferable learning to farming and agriculture, both for them and from them, that we need to learn from if we're going to dent antimicrobial resistance in humans. So what's the solution? And others have spoken about the key facets, and antimicrobial stewardship is only one, and I think almost the smallest one, especially in middle and low income countries. Sanitation is by far the biggest issue if we're going to dent antimicrobial resistance. And I think framing resistance and discussions for developing countries in terms of sanitation and access to medicines is crucial, as Osman has highlighted. But I'm going to talk about antimicrobial stewardship, and most of the examples I'm going to give relate to children, because that is the job I do on a day-to-day basis, and most of the examples of work that I've personally been involved in. So it's useful to know where antimicrobials are prescribed, and they're predominantly prescribed in community-based settings. So although a lot of energy goes into thinking about hospitals, in fact, thinking about people prescribing, and Becky spoke about video prescribing or video medicine. This is where the bulk of antimicrobial resistance is generated. That said, the impact of antimicrobial resistance often falls in people in hospital. And I think there are different strategies, which I'll articulate in the coming slides, about thinking about these two environments slightly different from an implementation perspective. You've heard from Becky and Osman about the diagnostics. I think rapid diagnostics are being heralded as the savior of the planet in terms of antimicrobial resistance. And I don't wish to cast aspersions to other people's opinions, but I think we need to be realistic that there is a huge amount of energy, there's a huge amount of money to be made in diagnostics. And these pictures I'm putting up now were me walking around ECCMID, which is the biggest infection conference on the planet. This was last year, and about 75 to 90% of the stands there were from diagnostics companies, which tells us that a huge amount of energy is going into it. I think if one deep dives into the evidence base supporting rapid diagnostics, it's extremely scant at the moment. And although I do think in the long run, rapid diagnostics will play a significant role in the strategy against antimicrobial resistance and promoting stewardship, we're not there yet. And what I really want to talk about is getting the basics done. So with a lack of high quality rapid diagnostics, especially for bacterial infections, my opinion, and it's articulated in the paper I've referenced that was just published this week, is that we need to think about some of the social science aspects of antimicrobial prescribing. We have to get the narrative right for the public. Firstly, about self-care. So if you don't go to see a healthcare professional, and once again, this is very much a high-income country issue. It's very different in low-income countries where access is to both healthcare professionals and to medicines is far more of an issue. But in countries such as United Kingdom and other European countries, we need to start thinking about framing self-care in a practical and effective way. We need to think about implementation of guidelines, of clinical prediction tools and effective safety netting, data, and frontline prescribers having access to data about their own prescribing, I think, is fundamentally important. And lastly, as Becky spoke about in terms of the work Malcolm's done, effectively communicating what AMR is to the public and also to clinicians is highly important. So talking about some of the self-care work that we've been doing in the south of England for parents, we have worked with parents to develop resources that they can use when their child is unwell. And we know that children under the age of 5 make up a huge amount of the activity burden in healthcare settings across the planet, and they make up a large proportion of antibiotic prescribing. It's not so dissimilar to the frail and elderly to some extent, and both clinicians are risk averse when they see young children, and parents are risk averse in taking their children to see doctors. I'm not going to go into the actual resources themselves, but you can see an example of some red, amber, green stuff and some text on that screen. And this promotion of self-care has been driven by healthcare professionals. So by empowering healthcare professionals to promote these resources and this website to parents, the impact has firstly been on this slide here, a huge increase in the use of the website, which is both by clinicians and healthcare professionals. And it's currently getting about 800,000 hits a year for a population that it serves of about 550,000 children. So it shows that with healthcare professionals marketing such things, it can be implemented and used by parents. But the bit that I find more interesting is the urgent care activity data. And this is presentations to GPs. So these are community-based clinicians. And in the time that website hits has gone up, you'll see about a 10% drop in activity to primary care with no associated uplift of serious things going amiss and being left at home inappropriately. And so this is a really good step to reducing antibiotic prescribing if parents just don't go to go and see a doctor when their child has a self-limiting illness. It negates any possibility of their child getting an antibiotic. Another piece of work that we've been involved in the south of England is working closely with clinicians to change their approach to prescribing. And we heard a bit about that from Becky as well. We've used pharmacists that go into GP practices. They work alongside a GP who is a practice champion for AMR, and they access the primary care data, and they then educate. They run some education sessions as well as going through prescriber level data with those clinicians. And the resources they use are various national resources we have as well as local resources, and then they review their antibiotic prescribing. And so some of the work we've done with primary care in the south of England is to develop evidence-based guidance for sensible, pragmatic prescribing for children, and that includes the use of clinical decision tools such as for sore throats and ear infections that give some clarity about which children should and shouldn't be prescribed antibiotics. And the other piece of work we've done is develop safety netting sheets so that when a patient goes to see a clinician, a prescriber, they can go through this kind of red, amber, green approach to explain why the child doesn't currently need antibiotics. They can use that the facts about harms and benefits from having antibiotics to frame some of that discussion. And then they can empower the parent to go home and say, if your child's condition changes, these are the situations that necessitate your child coming back to see us. And with that approach, there have been some really interesting reductions in prescribing in primary care. So this was done in a region called West Hampshire, which is shown in blue, their antibiotic prescribing for children under 5 years of age. And that the counterfactual data in red is UK level data. And you'll see that over that time period of about a year, October 2018 to September 2019, there was a 6% drop nationally. And in our area, there was a 16% drop for children, which is a huge reduction in antibiotic prescribing over a 12-month period. And just to confirm that that wasn't something that was borne out across all ages, this is prescribing data over the same period in the same places. That's West Hampshire in blue versus England in red. That shows that for a different age group when there was no quality improvement strategy put in place, there was an absolute mirroring of the UK trajectory. Hospitals have been extremely complicated. Many of you will know that the sepsis agenda has dwarfed the AMR agenda, and the paranoia that surrounded sepsis has meant that antibiotics have been prescribed far more liberally than potentially than previously. And COVID has reinforced this. And as we heard from others, the prescribing rates in some places for patients with COVID has been extremely high. What has been done, and this is a very quick example of the Start Smart Then Focus strategy that was promoted by, or is currently promoted by Public Health England. There's work done with frontline prescribers to try and make them think about their antibiotic initiation and review at 48 hours. And this ARC review kit, which you can see more about if you click on that link or if you scribble down that link, is highly used by the feasibility within the feasibility study, and had an impact on stopping of antibiotics because it just made people think about why antibiotics were started. This is all hosted on some BSAC platforms. BSAC is a global charity based in the UK that has really focused on implementation in terms of AMR and education globally. We've done some work with children. COVID, as well as many other pressures on hospital beds, has meant that patients are increasingly being managed at home, even on antimicrobial therapy. And we call that OPAT if it's complex oral therapy or IV antibiotic therapy. And we have implemented antimicrobial stewardship within an OPAT service in our children's hospital with a huge impact on the quality of antimicrobial prescribing pre and post implementation of robust stewardship. And it shows that with some relatively simple measures, there can be a huge impact on the quality and quantity of antibiotic prescribing, even in hospitals. And we're currently developing some national common infection pathways to support clinicians rolling out this kind of strategy in hospitals all across the UK. And last is communication. I'm not going to talk much about public initiatives because Becky's spoken about that. The Reframing Resistance document published a couple of years ago is absolutely excellent for people that want to understand how resistance should be framed to the public. There's been some great stuff in schools. I think that these are places that we do have to focus on. Children changing their parents' attitudes to antibiotics is highly effective, and work has been done through Public Health England, through eBug. BSAC have done some social science work, which is developing a musical that school-age children have performed about Alexander Fleming. You know, Paul will be happy that that's some work that's come out of Scotland and has been highly impressive. A great article published just last month in the JAC AMR that really describes a lot of that public awareness and approaches that have been taken globally. And I'd signpost any of you who are interested in that to that article. We're currently doing a large piece of work in the UK with all the medical schools to try and ensure that medical students receive high quality teaching on AMR and AMS strategies as the prescribers of the future. And this piece of work involves many national bodies as well as all the medical schools in the UK. And will be rolled out, and the lessons from that will be rolled out to other healthcare professionals such as nurses, midwives, dental students, etc. And so a bit of a whistle-stop tour about implementation. It is a long road, of course it's a long road, but I think we're on that road, and I think we've got to be positive, but we've got to really focus as much energy as we do on policy as we should be focusing as much on implementation as we do on policy. I think there's a huge amount gained by the One Health agenda. And I think things that we've learned through human health can potentially be transferable to farming and agriculture and vice versa. And I think that the data and behavior change are fundamentally important and highly challenging. And I'd like to thank the Royal Society for Biology for allowing me to talk. Thank you.
Thank you, Sanjay. Another fantastic talk that really covers some of the pertinent issues that we're facing in AMR research and implementation and delivery of the One Health approach to combating this. So we've had a few questions coming in. So what I'd like to do is, if there's a couple of questions that are very similar to each other, so I might paraphrase some of these questions. If our speakers can keep their answers short and snappy so we can try and get through as many questions as possible, that would be great. So I'm going to start with a question that came in. Unfortunately, I don't know the names of the people who've asked these questions because they've been collated for me. So within the context of the NHS, what would be the best way to incentivize GPs in order to reduce the use of broad spectrum antibiotics? Does anyone want to wave their hands? I guess Sanjay is probably the most suitable for this.
Yeah, I think the approach we've taken in the UK to date has been quantitative targets. And I think that although they're very attractive and very easy to measure, I don't necessarily think that that is the best metric that we should be using. I think GPs want to do the best for their patients. And I think if they understand the harms to their individual patient, I think the framing of this to the individual is the way that we will be able to start changing prescribing behavior. And I think the incentive can potentially be financial, but it doesn't need to necessarily be financial. I think GPs want to do the best for their patients. The litigation around it is one of the more complicated aspects, and I think we need to get the medical legal framework around this more able to allow people to take some risk.
Great. Does anybody else have any comments, or we? No? Okay, I'll move on to another question, and I guess this is probably for Osman and Becky, really, is over the past couple of years, a number of biotech companies have gone bust despite large amounts of revenue each year from antimicrobial drugs. And what are your thoughts on nationalizing the antibiotics search and manufacturing and distribution, and how could this come across pragmatically?
So I can jump in first, and it's also particularly relevant to COVID because that's starting to come up a bit more as well. We don't have manufacturing capacity here in the UK to start to do that yet. Things would need to be built up, and it may be something that comes out of COVID that more countries start to do that. It is tricky, but I mean, at the moment, it's not an issue of manufacturing capacity. It's that we need to work these things through. So there is a potential of taking the whole development cycle in and within governments, and that would be something that would be possible if you were able to follow it up. But it's not an option that's readily there and that we can jump on yet. And so we have to be looking to develop the policy options that can fit in with what we have, whilst then encouraging alternative ways of thinking for the future.
Yeah, I guess I'll weigh in on this one. There's a little bit of history around this. I mean, it's important. One thing that's important to remember is that the regulators, the biggest regulators in the world, the FDA, the Federal Drug Administration in the US, and the EMA, the European Medicines Agency in Europe, one of the issues with them is that they're by and large funded by big pharma. So the FDA's gets 70% of its budget from big pharma. The EMA gets 80% of its budget from big pharma, and so in my mind, there's a little bit of a conflict of interest when it comes to the regulation and the end stage development process with antibiotics and with drugs in general. In essence, what's happening is that the public sector, big foundations, they're taking the risk in terms of the early development process, because they're funding all the blue skies research and all the really innovative development stuff that's coming out of academics and universities. And with antibiotics, the big pharma is expecting the public sector again to take the post-marketing risk as well in guaranteeing purchases, and they only then have to pay for the bit in the middle. They pick the best candidate drugs and put those through clinical trials, but everyone else, all the smaller companies, are priced out of that. They're not able to enter that because the regulator keeps that development process that expensive, and so there's an incentive for both of them, for them to keep the end stage development process expensive, and for big pharma to keep it expensive as well, because it keeps smaller players out of the market. And so I think there's this conflict of interest that plays out. Now, in terms of nationalizing the whole process, that's a real problem. A good example, and I know I'm droning on again, but a good example is what's happened with remdesivir, which is the new drug that Gilead's produced for COVID. They initially applied for orphan drug status with that, which would have given them even more pricing rights, and they could have charged an even higher price for the drug. But just the threat of them being brought under the Defense Production Act, which is a US piece of legislation which allows the government to take over manufacture and development processes, which is what they used to threaten the car companies when they wanted ventilators to be built in the US. That's what they used to threaten them. So they used that again on remdesivir and said that we'll take this into public ownership or force you to manufacture it. and then suddenly they drop their application for orphan drug status. They said we'll produce this as a sort of global public good type thing and at cost price and distribute it. And that's the kind of thing that then works. So you don't necessarily have to nationalize the whole system, but just the threat of that legislation and putting it into practice can bring big pharma into line. And that's what's needed in this space.
Great. We have a question that I guess is probably in the sphere of Katharina, and it relates to something that came up to my mind when you were talking as well, Katharina, was we often think about One Health approaches in terms of agricultural management and companion animals, but how do you think AMR plays into wildlife trade and treatment of wild animals, vaccination of wild animals, and the whole broader trade for food and also for pets and the trade in those kinds of animals?
If you refer to the issue as sort of very generally, and I know that there is now a lot of debate around the origin of pathogens and the role of and encroachment of human activities on wildlife habitats and how that facilitates the exposure of humans to pathogens that we would normally be exposed to. I think that's been accepted for some time, that this is one of the drivers that facilitates also species jump for certain pathogens, and of course these are very complex issues. So human activities impacts on habitats in a number of ways, and this one aspect that this might also facilitate exposure of humans to certain pathogens is what I think is probably, comparatively speaking, a relatively small aspect. If you think of sort of virgin forest clearance and impact on even minority populations who use maybe some of these natural resources in their own traditional way. I mean, it has so many aspects that probably dominate, or probably should dominate, the discussions around emerging pathogens. I'm also aware of sort of this let's call it like virus hunters. They go out and they try to identify like what's the next likely pathogen. I personally, this is my personal view, I think I'm much more on the side of, I think it was Becky who talked about sort of general preparedness, and I think that's where we our investments are much broader value if it's sort of applied in a generic sense rather than specific, because I think the probability of us to being able to identify like what's the likely next pandemic causative agent are minute. But if we can be well prepared and in a One Health sense, I mean, if we can establish contacts between the different disciplines, between the different agencies, if we can put in place mechanisms that can accelerate response, and also what we've been discussing tonight, sort of if we can reorganize value chains in a way that make them robust to all kinds of disruptions, I think that will be much more promising.
Thank you, Katharina. So one of the problems of doing this remotely and not in person is that we can't carry on this discussion over a refreshing beverage after the talks. So we've got one last question, I think, which is pertinent to the kind of the points that everybody made. And I guess the reality is, so the question is, the reality is that most, if not all, antibiotics for veterinary use can be bought without prescription in certain parts of the world. how can we address the issue of buying these kinds of drugs without prescription? I think this not only is pertinent to veterinary medicine, I think that also goes to areas of the world where you can buy these drugs over the counter, and also links to something that Osman touched on, which is the counterfeit drugs and drugs which are not necessarily what they say on the packet. So they may say 50 mg per mil, but the reality is they're about 20. So you're delivering suboptimal doses of drugs. So I don't know whether anybody wants to come in with their hand up quickly and address that question of how can we address prescription and control of use?
I have to admit, I think a bit of me thinks that isn't the right question to ask. I think Osman nailed it when he spoke about access to healthcare facilities and to medication. And I think we can be very critical, and we are very critical in developed countries about this ability to buy medicines over the counter, buy antimicrobials. But that's partly because of a lack of healthcare infrastructure that allows them to go and see someone who can then make the decision about whether they need antimicrobials or not. So, yeah, I think it's a difficult discussion.
Anybody else wish to come in, Becky?
Just to jump in, more on the human side than the animal side, but the same would apply. We did a series of films called Promoting Pioneers, and we highlighted a project in Tanzania that was working with people who are working in pharmacies, but who aren't qualified pharmacists in the way that we would have them here in the UK. And actually there was a training program delivered through those pharmacies, because that is how people are accessing their drugs. So you have to look at how the system is set up within a country and work with that, and work with the people who are the ones that the general public, and it'll be the same on the veterinarian side as well. How are farmers accessing their antimicrobials, and how can you go through those mechanisms? You're not going to change something overnight, and you can't bring in restrictions, because as Sanjay says, that has a real impact on access, and access is still an issue in the veterinarian world as well. We need to make sure that animals are not suffering because unnecessarily, but equally that they're not getting these drugs when they don't need them. So you have to go with the system that's there and work through the people who the public or who the farmers are accessing to get those drugs, and try and bring in processes that are suitable to that situation.
Thanks, Becky. I mean, I think you nailed it in your talk, which was very stark, is that we're very fond of banging the drum for AMR, but actually many more people die through lack of access to drugs than through AMR. And I think for me, that's going to be the big take-home message of what what everybody said this evening. I realize we're over time, and I'm sure we could carry on going for a long time, but I certainly need the toilet. So unfortunately, we can't give you a round of applause. So that's the sound of many hands clapping, I'm sure, for everybody. There will be, it's just popped up in your chat, is a link to SurveyMonkey. If you could fill in how you felt the event went, and hopefully we'll be able to do more things along these lines. If you didn't get your question asked, I'm really sorry. We had an awful lot of questions. The panic as a chair in these situations is that quite often you get no questions, and as a chair you have to think up all the questions, but that was definitely not the case this evening. So thank you all for participating. Twitter has been a bit of a storm, which has been great, largely because it looked like I was being effluxed out of a bacterial cell, according to Adam Roberts. But I'd just like to thank everybody for attending as a participant, for all of our speakers, for committing the time, especially those who have got much more pressing things on their plate at the moment in terms of COVID and addressing that. So thanks everybody, and thanks to our sponsors and to the staff at RSB for pulling this all together. Thanks again, everybody.
Thanks everyone. It's been a pleasure.
It's been a lot of fun.
Yeah, thank you, Paul. Thank you all.
Thanks, Paul.